for the security, what do you think is the best strategy that we can apply? Constant talking, engaging. What do you think we can still continue to do? Because we are trying to fight this pandemic, but we're having this so tight on our hands, making it extra for frontline staff and the securities to work effectively. Thank you, Mr. Chairman.
Mr. Chairman, when some of the officers, police officers, engaged some people in Toko who were defying or flouting the rules, I heard an interview where Bukom Banku, one popular gentleman, the boxer, claimed that he had not been engaged, talked to the youth. And the point I want to make is that sometimes the relationship that a messenger has with the people has a way also of making people comply. So maybe we can engage. Yes, he claimed he doesn't believe because he has not been educated yet. And that in itself is an admission of a problem, that you must get some of their heroes educated so that once they are on board, their people follow naturally. And so I know we are in an era of social distancing. We should not have large gatherings. So it might not be possible to get chiefs and family heads to come and sit, but we can call them. We can use radio. I think radio is powerful. People are listening to radio and watching TV. We can, instead of a doctor from La General Hospital going to a radio station to speak to the people along the coast, we should educate very well a traditionalist who is speaking to the basic measures. When he's talking on radio, that keep a distance, wash your hands. This is how we are all saving our lives. Naturally, people will comply. So we should identify messengers who have a link to the people we are targeting, and we'll get results. I thank
you. You said you had a follow-up. Just a follow-up.
Yes, Mr. Chairman. On the same point, having done all the public education, and quite a lot of it has been done, many of them would not claim they don't know what is happening, and yet people, residents along the coastal communities and in some of our inner cities are flouting the stay-at-home and lockdown restrictions. Many opinion leaders have also been involved. Now, some of them, including the Bukom Banku you cite, has been heard saying just this Monday that the people of Bukom do not believe that any such disease exists. Now, would you advise that we impose a curfew to enforce compliance with the stay-at-home rules?
Honorable Minister, may I ask, is it possible to give some of those who don't believe a shock therapy? Let them be infected and then they can then come and tell their story.
Maybe more stringent measures need to be adopted. That's why I'm asking whether considering the imposition of a curfew may enhance or enforce compliance.
I was actually speaking to him.
Mr. Chairman, I spoke to one senior Ghana person in this country. I already mentioned his name, but he's very supportive of a lot of the coastal fisher folks. And he told me something that I have actually put in my pocket, which has helped me a lot. That when you meet a Ghana who is resistant to good advice, don't make the mistake of thinking he doesn't like you or he's trying to be stubborn. Maybe you have to have a chat with him. There are some small issues you must deal with. Sometimes there are people who feel that if you take an action without first mentioning to them, it means you've not recognized them. So they would resist your activities so that should you fail, you know that they matter. So you'll be surprised that this gentleman, a 1 minute chat with, in quotes, someone who is relevant or who is in a position, he will be the most powerful advocate for social distancing. As for the curfew, the powers of the state allows us. But I believe we should explore some of these things, and the results will be fantastic. They will yield. Yeah.
Samzahi, before we come to majority.
Thank you very much, Mr. Chairman. Mr. Chairman, as part of the measures to ensure that people respect the partial lockdown in the affected areas, the President, in his last broadcast to the nation, asked that those vulnerable in society must be helped by way of providing food assistance. But when the program started, we've seen a lot of challenges in distributing those cooked food to beneficiaries. It actually violates the social distancing rule, because you see a group of, say, 100 people competing for their share of the cooked food. My question to the honorable nominee is, don't you think it's better for the government to rather supply raw food stuff, such as raw rice, to beneficiaries instead of cooking food and people assembling, crowding themselves to get their share?
I thank you very much. So the strategy of this country has been to handle this COVID situation with a five-pronged approach, where the first one had to do with limiting the importation of the virus. The second one is to contain community spread. The third one, providing adequate care. And the fourth one, which I believe you are speaking to, has to do with providing some social and economic cover for those who will be adversely affected. Now, I must say that the government has applied various ways of doing this. There is dry food going out there together with cooked food. And I'm happy to say that myself, I was privileged to be invited when a donation was made to Action Chapel to distribute food, canned fish, oil to vulnerable people in that catchment area along the Spintex. I was there with the Honorable Minister for Communications. So that one is being done, but I believe you agree with me that we have vulnerable people who might not even have the infrastructure or the facilities to put the food together. There are people who buy food daily from outside. They don't have, if you are not careful, when you give them rice and oil, they will ask for LPG gas and a cylinder so they can put the food together. There are folks like that. There are people like that. And that is why this cooked food strategy also came in. I admit, every program that you implement can or would have some challenges. And if once we observe that social distancing is not being observed, I think any suggestion on how to do it in a way that complies with social distancing should be tolerated and not resisted. So I tell people, let's find nice ways to do that. Let's remember that the one who goes with cooked food actually has the intent of saving lives. He wants people to be alive. And we don't want a situation where when COVID is done, there will be more deaths related to hunger, hypoglycemia, than the virus itself. Yes, there are people who go into hypo. When their sugar levels go down, it can kill you from hunger. And so you want to save a lot of lives. And so the intent is noble. But if the process can bring issues, we should take a look at the process. And I believe we can do better in some areas. There are some areas where they've observed social distancing. I think the police and others helped. We can replicate that across. Yes, I thank you.
Thank you, Mr. Chairman. Mr. Chairman, we are trying to prevent and contain the COVID-19. And it seems to me that our focus is mainly in Accra, Kumasi, Tema, and Kasua areas. I don't see much being done in the areas that have not been affected. There are about 6 new regions without regional hospitals. The old regions, they have regional hospitals, so you can agree that they are ready if they should encounter any of the virus. But the new regions, like the Western North region, who doesn't have a regional hospital, what do you think government should do specifically to ensure that we will be ready to provide healthcare to such people? Because it will be difficult for them to be sent to, say, Kumasi, for instance, from Sevi also. What do you think we should do specifically for newly created regions so that they can help to contain the virus?
Thank you very much, honorable colleague. Mr. Chairman, when I participated in a discussion on CTFM some few weeks ago, I mentioned that there is a principle or a reason why the president mentioned Greater Kumasi metro area and Greater Accra and Kasua. The reason was that some of the imported cases, or majority of them, happen to be at these areas. Now, so they have, in quote, elevated risk compared to other areas that, let's say, we have not recorded cases. And I actually stated that in as much as the president said there should be some form of partial lockdown in these areas, wherever you find yourself in the country, you shouldn't go like, I can do whatever I like, because some form of limitation in your activity would also reduce your risk, because you never know. Only one person might have been in your area, but tracing would have found the person to be, let's say, positive. So I heard someone say we now have a case in the Volta region and all that. But I told the person, it doesn't mean it was yesterday that we had a case. The sample was taken, let's say, a week ago. But the good thing is that anyone whose sample is taken is told to either quarantine on his own or is assisted to be quarantined to prevent community spread. So all I'm saying is that wherever you find yourself in the country, some places have been mentioned because they have elevated risk. But early limitation in your movements would help you, because you never know where you encounter someone. About the regional hospital, I'm happy to say every region, all the 16 regions, a place has been identified for treatment. So luckily, you don't necessarily need to treat people unless you're a regional hospital. We know there are 1 or 2 gadgets that are important in managing complications from COVID. And one that has become very popular, which a lot of people know about, is the ventilator. Luckily, there are modern ventilators which you can move to a specified wing of, let's say, a district hospital. So that if you have a case that is severe, you can take care of that person. So, honorable member, you can take care of cases at the treatment center. And every region, as we speak, has been identified. They have an identified treatment center. It might not be a regional facility, but it will be a facility either at the district level, a health center, or even at the chief's level. Most important is you have beds, you have someone who is trained to handle the patient, and you have a gadget to assist in times of complication or severity. I thank you.
Mr. Chairman, the honorable nominee is quoted to have said that, to quote, it would take a miracle for Ghana not to exceed 600 coronavirus cases, unquote. Is it because you didn't believe in the programs by the government? Or why did you, or you were prophets and you were prophesying what was going to happen? Is it because you didn't believe in the program laid down by the government, or why? Why did you say that?
Yeah, Mr. Chairman. And so there is a branch of studying public health, they refer to as epidemiology, which looks at disease patterns and the factors accounting for the pattern. And so once we had over 150 cases being imported into this country, what I said was that I tried to make people understand by saying Apollo is actually called viral conjunctivitis. So Apollo is a virus. So imagine how Apollo spreads in one house. So the point I made was that the mere fact that you have 150 cases which have come into your country, your measures are supposed largely to the barest minimum and even community and family spread. But there are some spreads or transmissions you really cannot stop. So I did a modeling and said, with the best measures, Ghana with my knowledge. As for the graph, people should psych, and I wanted to psych people so that they know that these are not to ensure zero transmission. COVID has a transmission rate of 1.6 to 2.0. What it means that if you have 150 cases, you have to multiply by 2, and multiply again by 2, and multiply again by 2. And that is why Switzerland in 1 month, they had their first case just around when we had our case, I think somewhere on the 9th or 10th of March. They are doing 25,000 cases as we speak, more than 25,000. Germany had their first case somewhere middle of January. They are doing over 100, I think 30, 40,000. Italy is doing hundreds of thousands. Which thinking that they have broken down prevention measures. But you judge a country not by the number of cases they have, but by the number of cases they could have had without any intervention. So if Ghana had not done any social distancing, we had not done any closure of our, these cases we are actively fetching who are not yet ill. If we have not done all this, by the modeling, we should have been doing minimum 10 to 15,000 by now. So you should not be complacent, but you should not also become despondent because your figures are going up. Your measures will limit transmission to the barest minimum, but there is a level of unavoidable transmission that you cannot take up. That's why I mentioned those figures. Thank you.
Honorable Minister.
Thank you, Mr. Chairman. Thank you very much. Mr. Chairman, let me congratulate Dr. Bernard Oboy, the nominee. He's one of the few ministers or deputy minister nominees that the president will put in his communication the need to expedite action on his the process of approval for him to join up, to take up a fight. I've also been watching him on television, and we all agree that he's been doing very, very well. But I still want to get from him a question that would always come to every nominee. What do you bring on board? Honorable Bernard Okoboy, you are going to assist your minister. At the personal level, at the professional level, and of course at the political level, what are you going to bring on board to assist him? Educate me.
I thank you very much. My minister works with directors. In this COVID situation, is working with coordinators who have been appointed by the president. He's supposed to be taking a look at reports from all different platforms and make decisions or give definite advice to the president. My appreciation of my experience with disease patterns, my experience with working in the Ghana setup in terms of service delivery, having worked, even my recent experience also with Kolebu, what I'm going to do is to also take a look at the things that are coming before him and make him share my thoughts with him whether the recommendations that are coming should be swallowed wholly or maybe should be swallowed in part and all that. So more or less, it's going to be an assistance role where I respect the competence of all other people, but with my background, I'll be in a position to tell him the what's the claim, the prospects of a recommendation are really what is being mentioned by whichever officer is speaking to the minister. And this I will not necessarily be doing openly. It's a boss assistant relationship, and that is what I bring on board. I say this because I'll give one classical example. If you get numbers or positive cases, and the number is given to you in a raw form, if you don't get some discussion, you don't get some support in terms of what it means, you might follow the recommendations and take an action which might not necessarily be warranted should you have had a discussion. So I am not going to teach the minister what to do. I only want to share my thoughts based on my experience and my background. Yes.
Mr. Chairman, I'll leave him at that. Stigma. Mr. Chairman, the biggest threat to this new disease called COVID-19 is stigma. Mr. Chairman, yes, there are deaths. 8 out of 636 people have died. As he rightly says, 17 have recovered fully. We expect by today, when another 66 were to take up their second test, they will be negative again. And so you have 83 recovering fully by the close of today, hopefully. Mr. Chairman, CSM has killed more and continues to kill more than COVID. But you have young men and women across the entire nation rejecting their facilities within their area to be isolation centers just because of stigma and the fear of this COVID disease. You have people being stigmatized, families being stigmatized because of this COVID, the fear of the COVID disease. Like I said before, just the last 3 months, CSM has killed almost 4 or 5 times than what COVID has killed. In fact, malaria has killed more than COVID in Ghana. And other diseases have actually killed 10 times more than COVID. So I want to find out from the nominee. In Ghana, yes, it is a bad disease, but it's not as ugly, and it will not be as ugly as other what we are seeing within the West with what we are currently doing. And I hope that it continues like that. What will you do, having this opportunity on being live on TV, people are listening to you? What advice will you give the people of Ghana to be able to combat stigmatization of this COVID-19 disease?
Thank you very much. And forgive me to use the phrase, some people say the devil you know is better than the angel you don't know. It's true that if you look at the fatality or mortality rate for COVID-19, we are talking about average 4-5% in the developed world and about 1.24 or 1.4% in Africa. So it means if 100 people get COVID in the developed world, let's say you might lose 5 of them. In Africa, you can lose 1. So the point I want to make is that its mortality rate is actually lower than a lot of other conditions. But the reason why people are scared is that it's a new, in code, that is a new release. In the scientific community, it's the first time the virus has been isolated. And that in itself gives it some notoriety. Now, for stigma, I think it's education is the best thing that takes it out, where we continuously tell people how it comes about. I was having a chat with someone, I said, this is not a disease of vice. In code, there are some conditions you get because in code, maybe you had engaged in something which amounted to a vice. So someone will say, okay, I don't want to get near you, you deserve it. But this, anybody can pick it. It's like a flu. So once we do the education, it helps. Going forward, there is one tool which is very potent in dealing with stigma. Because people don't know what COVID-19 is like. If they hear it, they want to stay far away. Some of our recovered people, we have to find ways to encourage them to start having one-on-one discussions, doing some TV interviews. Our sister Gifty Auntie, when she was mandatorily quarantined, she tested negative twice. After having a discussion with a senior journalist, a lot of people appreciated how it felt like to be tested, being in mandatory quarantine, and it came real to home. Until we get those people, everything I say or you say to them is imaginary. So they want to see in real physical terms a COVID patient who has recovered. So the person tells them, I am the one. I am he who was positive. Here I am negative. And they go like, oh, so this thing is not a big deal at all. So that is one of the very potent tools we have to use. And if we speak to those who are positive, they should help the country to come up, and once that happens, a lot of the stigma will start going away.
Mr. Chairman, the last question. The president has put in some steps, closing the borders, quarantining people, especially the last, on the 15th and 14th and 15th of March. We would have been having 105 people being unleashed into the system that were not done. As you stated, putting some restrictions across the country, not just Accra and Kumasi. And then having some more restrictions for Accra and Kumasi in particular, including Kaswa. I want to find out from you, going forward, for both the countries, the areas that have been, I'll use the word lockdown, though I don't like that word. I want to use the word that there was some restrictions on Accra and Kumasi, not lockdown in particular. I want to find out from you, going forward, and for the whole country, what new steps do you believe will help and work that you think that we haven't yet put in place that we should be thinking of putting in place?
Yeah, I thank you very much. Let me say, Mr. Chairman, largely, most of the measures we've put in place, if not all of them, have helped us to have these numbers that, forgive me to say, are encouraging compared to others or elsewhere. Going forward, like I mentioned earlier, it is the numbers we get as adding to the current figure of 636 minus those that are recovering that would actually tell us whether we stay at where we are with the measures on restricted movement or we escalate it. You don't want to escalate it because another country is escalating. It is your situation, it must be local. Your situation must warrant your action. And let's say, if in Eastern region, let's say they had no case, now they have 20 cases. The next question is, are the 20 cases scattered across the Eastern region or were found in one compound? If you want to take a decision on the 20 cases, if the 20, you had 5 in Chebi, 5 in Asamankasi, 5 in Koforidua, and 5 elsewhere, being scattered might warrant a restricted movement because it's scattered. If they are all in one compound, you might say that because it's contained, you don't need to shut the whole region down. So every action will be based strictly not only on the numbers, but where the numbers are located and the risk that comes with the allocation. And so I don't want to preempt some of the actions that can be taken, but I think so far every escalation has been connected to an occurrence, and that is the way to go. Thank you.
Thank you. No, before you.
Thank you very much, Chairman. Congratulations on your nomination. I have been following your progress as chair of Kolebu, and you and I have had several discussions about the measures that you've been putting in place trying to improve the situation at Kolebu. My initial question was going to focus on stigmatization, but it has been asked by Minister for Defense. And if Chairman will permit, how soon, as a follow-up on the Defense Minister's point on stigmatization, how soon will you deploy the disclosure of the identity of cases as a way of dispelling the myth and fear around coronavirus? Because it's, as indicated by the Defense Minister, it's not a disease of vice. By you, actually, it's not a disease of vice. Touch wood, and I don't pray that that happens, I could just get an infection because I touched this table. Something as simple as that, that I came and sat here, that was all. That I sat here in response to a national call could be the source of my getting infected. So what is it about publicizing that? Oh yeah, I got up this morning, I was coughing, I went to the hospital, they tested me, and they found me positive for coronavirus. One, it makes contact tracing easy because all of you who are in this room will own up and say, well, I was in the same room with Mahama, this morning. No, but it will help. But it will help with those of you, because it's not possible that if you took me into a room and say, give me a list of all the people that you have contacted with or come close to, I may not notice the man standing behind me with the camera. I may not notice half of the people who are around me. But the people around me may have noticed that they were in the same room with me. And so it helps with contact tracing. And also it helps with people just taking precaution. Because the problem we have now is getting people to own up.
Honorable, kindly answer your question.
Yes. So when will you, in my opinion, as a communication strategy, I don't think it's for nothing that the British disclosed that, what's his name? Boris Johnson was positive, the media was on him, and etc. And all those high-profile cases. In some situations, as a communication strategy, it could just be to dispel the fear. So when will you, as a communication strategy, start doing that as a major tool in fighting the coronavirus?
Yes, thank you very much. So when we were checking the temperature of people coming into Ghana, UK was relying on the manifest of flights to see whether anybody was a risk or not. They wouldn't check you, let you fill forms. But they educate you that when you get home and you're having symptoms, call the special number. The point I want to make is that they chose that route because the architecture of their society is such that majority of their people, if not all, appreciate the dynamics of reading and writing and all those things. So we chose checking and stopping you, and then later escalated to mandatory quarantine. The point is that they can afford, based on the societal makeup, to, let's say, have a minister's result declared and all that. Now, what I would say here is that we have gold standards for medical practice, be it public health or be it curative medicine or preventive medicine. In public health, it is not necessarily a gold standard that if you test somebody for a particular disease, you should necessarily put their details out there. I say it's not a gold standard. Well, if it were to be a gold standard, then I would encourage Ghana to do same. But the opposite is that people are encouraged to disclose their identity so as to help bring down anxiety in the society. And even in Europe or America, it's not all the positive cases that voluntarily allow or come up to say I was positive. So that's why I said we have to encourage those here. And it comes in a lot of forms. You must speak to them, do some therapy. Some will ask you, how do I handle my family? Once you assist them to know how to manage the post-interview period, they will be willing. So, in fact, even malaria, if I'm doing a report in the hospital about our cases, I'm not supposed to say, Honorable Mama Yariga came with malaria. Normally, even with malaria, I would say maybe MA. Patient MA visited us at such a time and was treated for malaria. We mention your condition, but not you, the person. But if you decide to be a malaria ambassador, then we will gladly take you so that you let the world know that malaria is real. Keep your society clean, but should you get it, you can be saved. I'm a malaria. Mandela was a TB patient. He does advocacy that you can recover from tuberculosis and still live long and live a normal life. So we have to encourage the positive cases who have recovered. You can imagine the optics. We also have to work on ourselves. There are people who would even refuse to sit with a positive person. But if I am having a breakfast with a recovered person, people will say, but doctor met him and he's cool. So we have to work on them to support us. It cannot be compulsory. You can't do that. You must convince them to come out. Yes.
There are two issues involved here. There's the medical issue of people getting infected, being treated, and etc. Then there is the bigger issue of organizing society in such a way that we prevent people from getting infected, deploying methods like lockdown and etc. And you said that if we don't handle that well, more people could actually die of hunger than we will save from COVID. And so we allocated 280 million Ghana cedis in the lockdown zone to prevent people from dying of hunger. And there are 47 constituencies in the lockdown zone. By my rough calculation, if we were to divide this money equally, or fairly equally, every constituency will get 5.9 million Ghana cedis to feed them. We allocated 200 for utilities, water, and etc. for people in the lockdown area. And then we allocated 40. The 40 is for, first part of it is distribution of food, and then the other 40 is for buying food to also be distributed. The figures are there, yes. Oh, Parliament approved the money. Parliament approved the money. Yes, Parliament approved the money.
Honourable members, please. Honourable member, continue with your question, please.
Okay. Corrected. On the average, my analysis is that every constituency should get at least, when it comes to food distribution in the lockdown areas, we're looking at an average of 1.2, 1.3 million. It's still correct, please. I want to hear from the Deputy Minister nominee.
The lockdown areas have more than 40%.
47. There are 47 constituencies. 80 million. It's 80 million. It's 40 plus 40. The first 40 is money that buffer stock is supposed to buy food for distribution. It's 40 plus 40. That's 80 million. 40, the one that we're allocating to buffer stock to buy food for distribution. Then another 40 that is immediately available for distribution of cooked food. So that is 80 million.
Chairman, those figures are wrong.
Chairman, we allocated the
It is
money
wrong.
in this
Your
parliament.
figures are wrong.
Chairman. Yes, Chairman. This Parliament allocated 40 million to buffer stock to buy food. For what? For distribution. For distribution. 40 million. Then another 40 million has been given for food distribution. That's 80 million. It's 80 million. Go and check the records. No, go and check the records. We approved it in this Parliament. Mr. Speaker, all right, I want to find out from the Deputy Minister nominee whether or not he has been briefed on the protocols and procedures for determining who is going to do the food distribution and how the food distribution is going to be done. Are we limited to asking only health questions, health-related questions?
Are you briefed about food distribution and who is to?
No, sir. No, sir.
You, as one of the critical measures in this covert fight that we're involved in, okay? One of the critical measures is providing food for the vulnerable and etc. And you are telling this committee that you have received no briefing at all on how the food should be distributed, the protocols and everything. Are you saying that you have not received any briefing, and in your preparation for this vetting, you have no idea how the food is going to be distributed, so that at least the public listening to you will also be educated by you at this vetting?
Honourable Member, Mr. Chairman, I know gender and then local governments are handling the distribution, so I'm not too apprised. Thank you.
Very well, thank you. Honorable Jato.
Thank you very much, Mr. Chairman, for the opportunity. And congratulations, Honorable Okoboy. We're still looking at the curve. When we saw the 636, Ghanaians are alarmed until government came in to say that they are putting in a lot of measures by way of contact tracing to forestall this the spread. Will you shed some little light on it? And also, now that the disease is spread throughout the entire country, will you consider the drone services to transport blood samples immediately to the various centers to support the testing, the test samples? Yeah.
Thank you very much. So we started our management or regime for the COVID by testing those who were high risk and those who had more or less symptoms. And then we moved on to the enhanced testing, which is actually going strongly after those we suspect have traveled into the country before the lockdown and those who have come into contact. This measure of going after people instead of waiting for them to report that they are positive is responsible for some of the numbers that we are seeing. And forgive me, instead of being rather sad about the numbers, you should rather be encouraged that these are not people who came to the hospital sick or morbid, but you went to fetch them. Getting them early means that their risk of spreading it is low. And getting them early will allow you to put them on some medications or treatment that will prevent them from being severely ill. You have to forgive me, but there are some who will be captured in the COVID data only for statistical reasons. That once upon a time, they were positive for COVID and recovered. What you are interested in as a country is preventing their spread to others and not losing lives. So it is that percentage of 2 or 3% that can be severe from your numbers that you are preparing for at your emergency and ICUs. And the more you can keep transmission to the lowest possible number, the more that percentage of 2-3% is a small figure to deal with. So, assuming you even reach 1,000, 1 to 2% would be, we're talking about, in fact, 10% is 100, 5% is 50. If you have across Ghana 30 people to deal with at your emergencies, you will not have the Italy situation. So these numbers should be looked at from that aspect, that we are a country that is aggressively going to look for people and test them. And Nigeria's number is less than Ghana's number, but they've tested less than 7,000 people. What it means is that their graph is an imaginary curve. It is far from reality. In fact, almost every country has an imaginary curve, but some, their curve is close to reality than others. And the country with the closest to reality is supposed to be Germany and others like the US, who are doing a lot of aggressive tests. We are number 2 in Africa. We must be encouraged by our efforts, but we still can overtake South Africa if we want to. But that is how we should look at this picture. And I always tell people, you are judged not by the absolute numbers you have now, but what you could have had in the absence of measures. And so, and the good news is that not even one person is on a ventilator the last time I checked. It is 2 who are moderately ill. About 200 plus are asymptomatic. Asymptomatic means they are positive for COVID, but they are not coughing, they are not sneezing, they are like yourself and myself, but we've asked them to be quarantined. The drone, Mr. Chairman, the drone was introduced not only for blood, but for supply of all essential medicines. And whatever we are giving to positive people who are positive are essential for our definition in these times. And if a drone is what it takes, we'll use the drone to deliver it. Thank you.
Thank you very much. My second question has to do with the correlation between preventive care and then curative. That's how come His Excellency is actually championing cleaning Ghana and making Ghana clean. Will you, after assumption to office, support the work of the Environmental Health Service Division to be able to pursue aggressively the curative, the preventive aspects of healthcare?
Yes, I will.
Thank you very much. That's what I want. Now, about admissions into our medical schools. Most students are able to get aggregate 8, aggregate 7, and they are unable to get admission into the schools. I know you are a deputy minister. You will be a deputy minister after the House confirming you. Will you support the expansion of our medical schools so that at least we'll get a lot of doctors coming out to be exported, so to speak, to give some income to the country?
Will you or will you not?
I will.
Yes, Bogu.
Thank you very much, Mr. Chairman. Honorable nominee, congratulations.
Thank you.
My first question has to do with the issue of pets or animals in general. We are told that pets or animals in general can also have coronavirus, and they can transfer it to human beings as well. Can you share with the committee the role being played by the Veterinary Services Department in the fight against COVID-19 in Ghana here?
I thank you. Mr. Chairman, I made reference to some letters way back in January, some of the national coordinating committees that were formed. I'm glad to say that the veterinary services were captured together with other agencies. So they are involved.
Then in your response to one of the questions posed by a colleague here, you emphasize on the need for availability of hospital beds in this critical period. But you recall that not long ago, the issue of hospital beds became topical in Ghana. We were told that in Accra, we had 3,400 hospital beds, serving a population of around 5 million. So what is the hospital bed population ratio now? And how do you propose to deal with this situation if we are given the nod?
I thank you. Because of the background you gave, let me quickly say that when we had the issue with no bed syndrome, it really didn't mean that all the beds had been occupied. Most of the time, you had a situation where sick people were all going to one particular place, and then you have the issue of you can't get a bed. So once you improve the referral system and there's coordination, I mean, at the time they will tell you, let's say Lekman Hospital has no bed at the emergency. You have over, let's say, 20 beds on the wards and all that. So the hospital is like a factory. When you're on the belt, you must move. If you get a patient at, let's say, Kolebu emergency, and you are waiting for a CT scan from, let's say, Kaswa, before you can treat the patient, he will be there for 2-3 days. So once we improve our diagnostics, he can quickly be treated and move to the ward. And I'm happy to say that, I mean, that has improved this situation of no bed. But as a generic, naturally, anytime you add on beds, once the population is increasing, it's in order. And in Parliament, we've received quite a number of agreements that are going to build hospitals, like complete my honorable chairman's hospital at Bekwai and other hospitals across the country. So I agree that we have to add globally. Once the population is increasing, adding beds is important. I thank you.
I asked about the World Health Organization's recommended standard of 5 beds to a population of 1,000. And I wanted you to relate to the Ghanaian situation as to the ratio as we have now. Are we meeting the standard? Where are we?
Thank you. All I can say is that we are working towards that ratio. Government over the years has been adding up the bed capacity. So this is a country that is working towards that ratio, and I'm sure we'll get there. Thank you.
Majority, Kujo, yes.
Thank you, Speaker. My question to the nominee, Chairman, relates to just the word fake when it comes to delivery of medical services in the country, from fake materials to fake personnel and fake medicines. We know the impact on health delivery. When you think you are sanitizing your hand, then you are rather inviting the virus to the hands, because what you're using is rather viral growth enhancer. When you think you wear a nose mask to prevent transmission of the virus, you rather enhance the transmission of it. And then when you think you are getting services from a qualified person, you rather getting a service from. This is something that has big impact on health delivery. What are your thoughts on how we can minimize this as you take the position?
I thank you, Honorable Member. Honorable Mr. Chairman, as a country, we have legally established bodies that are supposed to assist in maintaining standards. Ghana Standards Authority is there, the Food and Drugs Authority. I got a call from someone who said our face masks that are coming from outside Ghana have been infected with the virus and all that. I mean, those are speculative realms. But what I can say as a way of giving assurance to our people is that the FDA, as part of their processes, go to certify products that have come to this country before they are released for use. In fact, you have to be accompanied with a certificate that shows the standard you have, and they have to confirm those standards here before you release them into the system. So that is what I have to say. In terms of fake doctors and all that, we've had reportage about some people who are arrested and all that. We just have to do a lot of monitoring and then report the cases too. Because for all you know, there's a lot of work being done, but some things, when they don't come out in the public, people assume that there's not much happening. So I share with you that it is monitoring, strict monitoring, that can bring out these miscreants. And we have laws.
Honorable Minister, so the title doctor, the academically acquired doctors, and the medically trained doctors. But the academically acquired, I agree. But there are those who say they are specialists in what nobody can verify. And they are called Dr. Who, Dr. High, Dr. Tabia, those ones. If those people are also practicing, will you call them fake doctors?
Mr. Chairman, then there are laid down processes that if you are doing unorthodox medicine, which is not, if you are not doing the one we all doing, they are registering, they have regulatory bodies that register them. The Medical and Dental Council, by their act, say they regulate doctors as in those of us trained through the traditional system. I have also had occasions to tell them that they have to be interested in those who carry titles like doctor, but are not part of their mandate in court, because they say if you are trained in Confanoche, the traditional, that's when they come to review your work. So it's something we have to look at, because more harm is caused outside the doctors who are trained. That's not to say traditional practitioners are doing harm, no. But I mean, fake people, you can have someone who is pretending to be a doctor in Kolebu. Usually they are not as many as those who are Dr. High, Dr. Days in their own corners. So we must try and find ways to bring their work to review as well. I thank you.
Thank you, Chairman, again. This morning, driving along the road, I could see some people selling these nose and mouth marks in African prints. And I was wondering if the material has enough yarns to really prevent this breathing in of the droplets or transmitting them out. Who is checking? First, the environment in which this production is actually taking place. You could see that these are not coming from properly laid out factories. You can see from the sewing, the threading, that these are being done in somebody's backyard. The risk involved, who is checking that they comply to those standards required to make them acceptable?
Mr. Chairman, in an effort to stick to the last leg of the 5-pronged strategy, which is building local capacity, Ghana, the government has engaged a number of companies to sew some of these materials. Those that will go to the hospitals will go through some form of sterilization before being applied. And let me be quick to say that the face mask that you see a doctor or nurse wear at the OPD is not the same face mask that is worn at the theater. So in basic terms, COVID, the virus can pass through your nasal route, that's your nostrils. Any item you put to cover your nose or mouth would help you reduce the risk to some extent. And all you want to do is to engage in an action that reduces your risk rather than elevate it. It might not be total, like the one in the theater, but at least once you have covered your nostrils, if I have COVID and it's in the air, at least your minister's face mask would hold it. So it's a barrier, and your handkerchief, anything you use. Just that you should be regularly cleaning the face mask with either a spray, a biocide, something that kills germs, or you should wash it with soap so that anytime you use, it is healthy, clean. If you use the same face mask for a week, it might have a lot of microbes, a lot of disease-causing organisms. Maybe you are better off without it. Yes. Minister washes hers every day. Yes.
Thank you very much, Chairman. Let me say congratulations to Honorable Okoboy. I'm really happy for you, and I wish you the very best. Around this table, though, I have heard people commend, including yourself, the President, for the March 21 to 22 lockdown that resulted in some Ghanaians and foreigners who arrived having to be accommodated and fed for a period, quarantined, if that's the word, and later tested, where we got over 1,000 of them, close to 1,000 of them, right? Testing positive. Okay. 100, sorry. 1,030 were quarantined and 100, about 100, okay. So I recall that the deputy minister that you will be taking over from was with me on a TV show. That was before we recorded our first case. And the discussion was around the students in China and the call by some of us in the minority then, especially our ranking for foreign affairs, for them to be airlifted back home. I recall he made the argument against that, citing two reasons: costs and threats. In the argument, if we brought them home, we're going to expose them, expose Ghanaians to any of them who may have had the virus, and that it was also going to be expensive. Now, on hindsight, we didn't bring them home. But eventually, but within that period, we allowed flights to come in from China and other countries. When we finally decided to stop them, those we quarantined had evidence of people who were coming into the country with the virus. Now, when you look at the scenario and the fact that our first cases were all imported, do you think we acted a little too late?
So, thank you very much. Mr. Chairman, when the thought of the idea of bringing students from China came up, for me, I will not speak too much the cost issue, but in public health, you don't want to pick people from a zone of high risk and bring them into a zone of low risk. So I also was of the opinion that it was good for them to be quarantined or take good care of themselves there rather than bringing them here. Maybe they might be negative, but the pilot can be positive. And those who clean the plane at Kotoka can bring it to the country. So bottom line is that you want to reduce the risk. It's all about judgment on risk levels. Prior to 21st of March, when we did a mandatory or we closed the borders, prior to that, we were doing the thermometer reading and the filling of forms. It was a way to pick people with elevated risk, so that if you had temperature, even without coughing, you are likely to be set aside. If your forms you feel showed that you had been to China or a place which is an epicenter, you are likely to be picked out. So we had measures that were meant to pick out people with high risk.
I don't mean to
I'll come to
interrupt
your
you.
question.
I don't mean to interrupt you,
All
but if
right.
I could just explain,
Yes.
the part that I want you to address,
I get
so
you.
that you get it clearer. The point is that if your explanation that you don't lift people from high risk area to low risk area
Yeah.
is to be, applied, why then at that point that we knew this and we're applying it to our students, we did not apply it to other people who were coming in from these high risk areas to this country? And that's where I wonder if our action was belated.
All right. So the point I'm making is that at your borders, you want to limit or stop the importation of the virus. Those actions of filling forms, those actions of, taking temperature and all that, they were actions that were supposed to pick out people with elevated risk. So closing it entirely is a measure, but it's an aggravated measure. And that is why even the European Union, from day one, didn't close their borders to other continents. But at a point, they closed it because they were monitoring the curve. You see, with hindsight, the benefit of hindsight, you can say, oh, why didn't you close the border in January? Closure of the border also has ramifications. There are things that can happen adversely to people because border has been closed. You can have someone who needs a surgery at cardio. A particular drug that should have been coming in can become scarce. You might, so there is there's an adverse consequence. So that's why it's a weighing of risk, ramifications of decisions and all that. So we should be careful not to. Most countries that have stopped their citizens from traveling, they didn't do it from day one. And the reason is justified. Because each stage you have, as we speak, nobody knows the virus 100%. People know maybe up to 70%, 80%. Any knowledge you have can determine the measure you take. And if we had closed our borders before 21st, this is what would have happened. The manifest shows that about 30,000 people entered this country. This 30,000, maybe you opt for mandatory quarantine. If 10% of 30,000, you pick 10% of 30,000, you are going to have a number that is, I think that's 3,000 is 10%, right? Yes. Now, this, if you look at the 1,030, 10% of their figure came out positive. That's 105 people, 10.2 or so. If you transcribe it to the 30,000 that would have quarantined, you are going to have a positive cases of, let's say, you are just transposing 3,000. This is what we're having. You would have had 3,000 cases all at one place. They have what they refer to as cross-infection. Because of the huge numbers, it would have been a camp that can get out of gear. It would be an incubation hub. So it might be convenient to say, but if we had closed the border some weeks ago, all this would not happen. But the person wouldn't have been looking at the risk that also comes with such a measure at the time you took it. Luckily for us, by 21st, 22nd, global action supported what we did. A lot of countries had reduced flights. They had stopped their citizens from traveling. And so anytime you are dealing with a condition that is global, some actions are possible when everybody is taking it. And so in 2 days, you had just about 1,000. If citizens had not been stopped across the world, you might have had 10,000. And you have difficulty in managing the 10,000. You can blow it out in terms of, you can have an incubation hub for the viruses. So it's a global trend. And sometimes you need your allies to help you take decisions. And we've done, it's not too bad a decision. Yes, it's not bad.
All right. I'm just coming from the constituency. In fact, I arrived this morning. And I took time to visit a number of clinics. My constituency, Tamale North constituency. Thank you. I visited a number of clinics. I interacted with many of the health professionals. And I'll take this opportunity to report to you that many of them are living in fear, especially because one phrase that runs through when you ask them about PPEs is woefully inadequate. That is when they have it, because in most cases they didn't have it. Some will tell you they just have about 5 gloves and maybe some nose masks that they were given, which are finished, about 20 pieces. And clearly, the PPEs are not, especially at the district level. You, until your nomination, I don't know if you still are, the board chairman of Kolebu. Even staff of Kolebu threatened to go on strike because of the lack of PPE. The CEO at the time said they had just 95. That is Kolebu, just 95. So you can imagine the lack of it in other parts of the country. My question is, didn't we have these PPEs in stores? If we did, how many were they? And how many have been sent at least to the district level so far? Have you been given any briefing on this? And if not, if you haven't been given any briefing on it, can you assure me that it will be one of the priorities?
You're entitled to ask one question at a time, though you've pumped in about 6 or so questions.
It's just
Kindly
PP.
focus them so he can
It's
answer.
just PP. So I'm asking if you know whether, if you have been briefed, whether whether we had PP in the stores or not, and how many have been sent to the district so far. PPs. And the assurance that if you haven't been briefed, if you go, it will be your priority. PPs. PPs.
I thank you, Mr. Chairman. So if Kolebu, for example, gloves that we have obviously will not be, let's say, 95, but we have a lot of face masks and all that. These are consumables. Consumables meaning once you use them, you have to throw them away. So we have to constantly do restocking. And for that, every country, including ourselves, we are working on that. I know I had a conversation with the minister, and there are a lot of processes that have been triggered to make sure that we continuously restock, because consumables, some are reusable, like goggles that you can sterilize, like some specialized scraps, but most of them, once you use it, it's gone. And even New York, forgive me for citing about New York City, some few weeks ago, the health department threatened that in 2 weeks, if they don't get restocking, they might have to close down the facility. The point is that most of these things you use, do you consume them? Kolebu has about average 1,500 nurses. And gloves, you don't wear them from morning to evening. So if each nurse runs a shift and each is using about 2 or 3 pairs of gloves, a day, you are in the thousands, just nurses. You've not talked about radiologists and all. So the point is that we must restock and have it in abundance. And we must communicate to staff our level of preparation. Because the Kolebu situation, my engagement with the CEO and management, some of the staff said they didn't really have an idea of some of the things management were committing themselves to support them in their preparedness. So you don't only act, you must also engage, and that must go across the country. And managers of facilities must talk to their staff so that you don't have staff maybe saying things because they've not seen some form of support. The 95 the CEO talked about are actually coveralls. It's a kit. It's a complete one, which you really wear in more or less taking care of a confirmed or a suspicious case. And those ones, they are not in the same numbers as, let's say, your face mask and gloves. Those are the ones you gown when you have a positive case you are dealing with. And Ga East, most of our treatment centers, you have it in numbers. Sometimes too, you see someone who is working at, let's say, a recovery ward, at a labor ward. You say, doctor, I also need PPEs. Yeah, you need PPEs, but it's not the part like the 95, which you wear face top down in handling a patient. So we also have to do some engagement with our people to appreciate all these things. I thank you.
Well, your example of a labor reminded me of one of the in charges that I met yesterday who told me she had to refer a pregnant woman to the Tamale Teaching Hospital because she was even afraid to be that close to her, because according to her, for if there are other patients, they can take care of them because the contact time is less. But for pregnant people, they say too close, but because she didn't have anything to protect herself, she was afraid. So the point again is, please, when you go, make it a priority. And I think we must also commend those who have, the public-spirited individuals who are doing a number of donations to some of these institutions, and encourage them. Now, I'm torn, my final question, right? And I'm torn between two that I have here. But I'll deal with education, because I think that is an area that we still need to focus on. Earlier, there were, suggestions to the effect that maybe we should take some draconian, measures for people to appreciate, that the virus is really there. I mean, injecting the virus and all that. I think that that's far-fetched. But you see, knowledge, in my view, and you can disagree with me, Doc, knowledge of the disease is not synonymous with the education that is required for one to be more responsible in protecting himself. I hope you agree with me. You can have the knowledge of the virus. You know that there's some virus. But really, does that amount to the education that is required for you to be, please, I think that you should, he's listening to me and he's getting the point I'm making. So I have thought about, for example, Doc, when you were nominated, a lot of people commended you for the manner in which you have handled the education. I've thought of a situation where if we didn't have all these private radio stations, we did not have all these television stations. Dr. Okoboy, just if we were living in the era where we had just GBC radio to carry out the education, can you tell me so far, even though government have agencies like the ISD, the non-formal education, the NCC and others, can you tell me that apart from the work that these private radio stations are all doing, what will you say has been government's contribution to the education that is required for the people to really understand what we are all up against?
Thank you very much. Like I stated earlier, you have to engage in information that will give the facts. And I think the leadership showed by the president, the updates that we get, I mean, they are broadcasted live on television. I heard you saying if we take out television, radio, and no, I'll come. Yes, I'll come to that. Because you are dealing with, I said somewhere that the influenza pandemic in 1918 that wiped about a quarter of the world population. It was so because of the setup the world had that time in terms of technology to diagnose, treatment regimes, and their media, how developed radio and TV were. Every generation and the advantage you get based on your level of development. Because we are in this era where you can reach people through internet, through the radio and TV, we can't take it away from the management of the situation. So here you are, you find yourself dealing with a condition where people must not come together. If it had been child labor or puberty rights, we'll tell people to go to the markets and educate the women. Now, in this situation, the markets are supposed to be more or less closed. If it had been another condition like maternal mortality, reporting early to the hospital, we'll engage the queen mothers. But this is a situation that tells you, keep your distance as much as possible. So the whole world is working on a virtual platform. People are doing more of internet conferencing and all that. So the architecture you have in terms of technology, your setting, cannot be taken out of your, if you say, let's assume you take TV out, take radio out, then we would have been in 1918 and half of the world would have gone. The numbers we see now is because of the setting we have, and we must add it to the strategy. By the way, as for attitudes changing in trying to address a disease condition, it is human nature. When people know that they have to avoid some foods to stay healthy in terms of their weight, they tell you it's difficult. The knowledge doesn't translate into change in behavior. There are special models that are used to help people change their behavior. And I agree with you, we can look at these models and see how to make sure that when people acquire knowledge, it translates into change in behavior. But these things are known in public health, that people can get all the knowledge, whether in health, weight management, corona, or anything. And you still have work to do. Yeah.
All right.
Honorable
Once again,
Biama.
congratulations to you.
Thank you, Mr. Chairman. Congratulations, Dr. Okuboy, for this nomination. My questions will be on the pandemic. The first thing I want to find out from you is what positive lessons which you learned from the health sector regarding this pandemic. Yes, go ahead.
Thank you very much. Mr. Chairman, so the first measures that were adopted by this country to help contain the spread of the virus are really not COVID-specific measures. They are general measures that every practitioner of public health advises when they don't know much about a particular disease. So washing of hands regularly, trying to keep away from persons or a group, and using sanitizers is a general rule that helps you avoid a lot of infections, and is one of the best experiments that was done in medicine, where several decades ago, they made a lot of nurses and doctors wash their hands, health workers wash their hands on one ward, and compared it to a ward where they were not washing their hands. And they realized that infections were a lot on the wards that didn't wash their hands. So the good lesson is that going forward, when COVID is gone, the measures should not go with it. Maybe a few, like social distancing, we have to maybe lessen it. Lessen as in, yes, but not shaking hands, not washing our hands frequently and all that. These are things that will save you from Apollo, my popular Apollo. They will save you from cholera, typhoid fever. Most of these conditions come from contacting the next. In fact, even meningitis and cerebral CSM, which was mentioned, close contact facilitates its spread. So these are attitudes that must be with us going into the future. And all these ventilators, equipping of our ICUs, they are going to benefit a lot of people who also have acute chest problems, like people who come with COPD, chronic obstructive pulmonary disease, people with severe asthma, any condition that will let you stand a chance of losing your life because of difficulty in breathing, you can benefit from the ventilator. So we are taking advantage to build capacity in some specific areas. Noguchi now is getting attention. A lot of them, they've had attention, but the attention has been increased, and this would sustain them in other areas. So these are positive lessons for us, which will go along. And the treatment centers, Kolebu is getting its fevers unit. We call it fevers unit, but that's where we have cases of serious infectious diseases. It's been renovated completely, and everybody is happy. We are not saying COVID should have come, but because of COVID, it's seen attention. And then we are building another facility, an isolation center, a new one in a short time, to add on to the capacity of the fevers unit. All this is happening because of COVID, and they are sorry. Yes, they are positive.
Yes, sir.
Thank you. Dr. Okuboy, as a professional, what should the public be expecting in the coming days and months regarding COVID-19?
Thank you very much. The first we have a lot of samples that were waiting for their results. Luckily, we've had a lot of them coming already. So if we are getting cases reported, it's from, most of them were samples that were waiting in the queue. It is my expectation that this week, and at worst, next week, should be the period within which we would have seen most of these results coming. That would have given us an idea of where we are likely to hit, as in the plateau, and then later see some dropping. So this week is crucial. Next week, maybe the first few days of next week will also be crucial. And then we would have known our smoothness level. Beyond these 2 weeks, any other cases that will come are likely to come in ones or twos from contacts that were traced. But this week and next week, you have backlog results that are coming. They are not a reflection of what is happening over the past few days. They are just a backlog. Once we've cleared our backlog, then there's no backlog where you have 30 cases come at a go or 40 cases. 1, 2, 4, 3. That one is allowable, and it will give us an idea how the graph will be like.
Well, given that beyond Greater Accra and Greater Kumasi, a region like Eastern region is recording high figures. As of today, maybe about 40. And then given the attitude of some people, including famous people who think that this is not a threat to us. And of course, the youth who want to let it look like it's business as usual, who had to be even stopped from going to beaches and those doing parties, etc. If you're given this opportunity, I'm giving you this opportunity to tell the whole world the magnitude of this pandemic and what can befall us if we don't take precautions.
I thank you very much. So, Mr. Chairman, this, I say that the statistics tell us that COVID is real and we have to take it serious. With a mortality rate of even let's say 3% in Ghana. What it means that if 100 get it, let's say 3 can lose their life. You assume it is far from you until a relative becomes part of the 3%. And in statistics, anytime you are the victim, it is not 3% anymore, it's actually 100%. So we should not take refuge in the mortality and say it will take a long time to get close to us. Let me even confess, myself, although I speak on COVID, it was not close to home until one of my very good, is more or less a father, became a victim. And since then, you know, the feeling has actually not been the same. So you should not wait till your relative becomes a victim. Take the measures serious and assume that you can be that one person that can be in a severe condition. And once we take such an attitude, it will help us to contain this particular COVID situation. Let's say Eastern region, if you have 30 cases that are positive, the absolute figure is not enough. You must now go behind the figure and look at where the cases are. If almost all the cases are in 2 compounds or 3 houses in a locality, you can lock down that area and contain the virus. But if you have 5 spread along 6 places, then you can consider letting the whole region take some limitation on movement, restricting it. So the science and the details will help us to know the decision. But wherever you are, even if you are in a region that is not under this partial lockdown, assume the person you are seeing has come into contact with, in quote, a burger and has it, so that you take good care of yourself.
Yes, Honorable Minister for Communication, now you have your turn.
Thank you, Mr. Chairman. Now, Honorable Nominee, we've been told that the spread of the pandemic is assisted by dense populations. It's easier to spread in heavily populated areas. We have registered cases in some of our most densely populated areas, particularly in Greater Accra, including my own Ablikuma West. There's Medina, Weja, Nima, Mamubi, Newtown, and areas like that, which have registered cases. Many of those places, people live in compound houses. More than 3, 4, 5 people live in one single room. How do you enforce the lockdown in areas like this, the stay-at-home order in areas, without facilitating the spread of the virus because of the very nature of the communities in which they live?
Thank you, Mr. Chairman. So the question is complex. Yeah. Mr. Chairman, yes. Yeah, my colleague, okay, my colleague MP says that it's a lockdown question. Well, Mr. Chairman, let me say that there are some structural challenges inherent in our system when it comes to enforcing some measures. We can up our game in those particular areas so that if you are relying on media, radio, and TV to talk to some people in particular areas where they are dispersed, in these areas we can look for tailor-made engagements, like once again, like I said, letting the imam himself do a public announcement, even if it's a van, a recorded message, telling people that confine yourself to your houses. If you step out of your room, you can be in a compound, but don't go out necessarily. So we must be biased towards them, biased in terms of dedicating more effort to, how do you call it, help them comply. And then we must be strategic so that it will not be that people are being hounded in a bid to enforce the rules. So we have to pay special attention. We can succeed with them as well.
And I believe also that it would help if those who are confirmed positive are quickly isolated from those communities and put in isolation centers so that we can stop the spread. But as you indicated, we really do need to engage more with the people in those localities so that they understand why some of these measures must be taken. Thank you for your answer. Now, we've also heard reports that because of the ban on funerals, our mortuaries are choked, even though private burials have not been banned. So what do we do? Or what would you recommend to your minister, if confirmed, to do to decongest the mortuaries in view of the fact that we may be seeing an exponential growth in the number of deaths, COVID-related deaths?
With the numbers and the number of severe cases you are seeing, I hope and believe we will not. Let's hope we don't get there. But Mr. Chairman, my engagement with constituents show that the information, the directive is not too clear with people on the ground, whether they can actually go and bury their dead in the normal numbers, whether they can bury with less than 25 people, or whether they can bury at all. So I think quickly we must look at a clear communication that will find a way of making people bury their loved ones, but in strict compliance with social distancing and strict hygienic protocols. I think the communication must be clear, and especially with our agencies that are helping us to enforce the partial lockdown. Once this communication is clear, when they see someone on the weekend too, based on their responses, they will also understand what is happening. So we must quickly work on that, because some of the mortuaries, I get some feedback that they are having an increase in, not COVID-related deaths, but normal deaths. Yes, thank you.
And then my final question, thanks for the answer. We all heard about your very passionate advocacy for the construction of the Lekma Road, which was very, very admirable. At what stage is it currently? Has it been completed?
Honorable Minister, ask your question.
Mr. Chairman, Mr. Chairman, I thank the Honourable Minister for Communications for asking this question. I thank all of you for supporting my modest self to get attention on the road. As we speak, it's about 75% complete. And the way things are going, Mr. Chairman, you continue to see your
It will have a
junior
positive
brother here.
impact on your primaries, I'm sure. Yes, Honorable Deputy Minister.
Thank you, Mr. Chairman. Mr. Chairman, I would like to congratulate our nominee. And we are all in support of your nomination because you are one of the few young gentlemen who has proven to be a real statesman. And we have no doubt at all your capability of handling this issue. But I have a very critical issue on medication. I think earlier on, our colleague asked about herbal medicine, the introduction or the management of it in relation to the current COVID-19 pandemic. It has been reported or suggested that some herbs, herbal medicine, can be used to help manage the COVID-19 pandemic. I'm very much aware of the existence of a team of research scientists and medical researchers trying to dive into the orthodox or alternative herbal medicine. And these people have gone through the protocols, the arrangements to ensure that the quality assurance is maintained. But I don't see the effort that is being made by the health ministry to include that, because if I look at your analysis, we know the number of cases that have been identified at this point in time. If this pandemic has an exponential growth, we are expecting more cases than we are experiencing at this point in time. But I am not for people who are coming out and giving the wrong information that we are hiding figures and all that. I don't think so. But I believe that the herbal medicine is contributing a lot to the preventive measures that is being put out there to address the issue of this pandemic. But
that Noguchi has to do PCR test is a capital intensive one. And usually they are not like maybe a lab that does blood count and HB where you can set up a lot in a short time. So if you realize the ones that we've added on board, like the public reference in Kolibu, by their nature they were almost in the position to do the test, just that you have to configure them, get the particular calibrations before you can apply them. So I'm sure we'll take advantage once again of this situation to have more of the Noguchis and KCCRs for today and the future. Yes.
What I asked you was, what do you think was the inhibiting factor that is preventing us from being able to whether reconfigure or set up new centers across the country?
I think first of all is the process. No matter how urgent things are, you can't bypass some steps to say you have a lab of the nature and standard of, let's say, Noguchi. There are things that you must go through. There are supposed to be standardization, there are supposed to be certification, so that when a result comes from that unit, it can be accepted globally. We've even had cases where a sample taken to one particular center, well established, invested in, goes to CDC, Center for Disease Control, let's say US, and it gives different results. So the point is that there is a standard that must be met. Being in a hurry will not be an excuse. So capital investment is one of them, and the process itself, it takes some time. There are other labs that you can set up in a week to do full blood count and all that. This one is a specialized setup. Yes.
Yesterday, I don't know whether you monitored the media. There was this private company that came to donate an equipment that could assist Noguchi to do testing on the ground. Did you hear that?
I was preparing for the interview, so I'm sorry. I didn't monitor it strongly. Yes, sir.
But yesterday, yeah, they did. So my concern is if a private individual could quickly get certain equipment for Noguchi, and Noguchi, I heard the director talked about how useful it's going to be. What is preventing a government from quickly able to acquire such equipment?
Mr. Chairman, kindly forgive me or indulge me. I don't know whether that equipment on its own, without support from other facilities they have at Noguchi, can do the test. I don't know as I speak, but I suspect that it might be a complement or it might aid in their work. But I'll monitor it well when I finish this process, and then if we can go that route, mention it to my boss. Yeah.
So if I may ask you, Chairman, when cases come up interland, how do they get to any of the centers for testing?
Mr. Chairman, so they have a special, first of all, there's a test kit. And the test kit we are using is for PCR. I mean, it's harmonious with the setup at KCCR and, how do you call it, Noguchi. I say harmonious because there are kits are specific to equipment or the setup you have. So I know we have this kit that if you have a suspected case, it must be used to take the sample. And then there's a specific transport medium, what must contain or hold the sample you have to the testing center. Again, I know of rapid test kits which are not necessarily going to look for viruses. Most of the ones being done in Noguchi and KCCR and the public reference are actually trying to isolate the virus and confirm its presence. I know that most of the test kits would depend on other chemical routes like testing for presence of antibodies and all that. So there are different levels.
Chairman, what I'm asking my colleague is, when facilities interland suspect that these symptoms could be corona, and they have to take samples and transport them to the centers for testing, how do they do it? Do you have an idea how they do it?
So yes, sir. So Kolebu has a COVID team. COVID team meaning it's a team set up specifically for COVID cases or suspects. Immediately you get any case that fits the definition, you have to alert the COVID team, especially their coordinator. He comes in. So if it's even a labor case, but there is grounds to suspect COVID, he comes to join the obstetrics and gynecologists to manage the situation so that they follow the protocols.
But this is callable.
Yeah, this is callable. At the district.
What happens at Joaboso?
Yes. So every district by our setup has a DHMT, a district health management team, headed by the municipal district health director. They have a COVID team as well for the district. So if a suspected case appears at a health center, the head of the health center must signal the head of the COVID team in the district, with the director of health at the district being strongly involved. I stand to be corrected, but the director is supposed to be the head of the emergency team. They will send a kit to where they have the case, plus a transport medium. And today, as we speak, every health facility has at least one person who's had some training on the approach to dealing with the patient. You might not do it all on your own, but you signal the chain so that you get support.
So you say every health facility. Did I hear you say that?
Mr. Chairman, it's supposed to have gone down to the last route. Every district has a team. If a facility...
No, I heard you say every health facility. I just wanted to be sure. You said every health facility.
Yeah, every health facility has at least one person who's had training in COVID approach.
So where from these 56 designated facilities across the country, if every health facility will have one person that is trained, where from this we have set up 56 across the country to deal with it?
So, Mr. Chairman, if you happen to have a suspect at the eye clinic, you don't want the suspect to be with the eye people. Once the fellow is strongly suspected, the fellow will be sent to a quarantine place, either mandatory quarantine under state supervision or strict at home. But once the sample is confirmed positive, usually you are handled at an isolation center. So these cases, places you are talking about, are the places where actually positive cases will be dealt with. And the level of, let's say, preparation and setup will be superior to a place where you are not necessarily structured for COVID, but you are sensitized enough to pick cases. So that is the difference.
So if a chief compound suspects the symptoms, they will call the health director, or what do they do?
Forgive me, but there are two kinds of people who might need a test. Those who themselves volunteer that they have a travel history without any symptoms, and then you want to do the test. The other one is the one who might be clinically ill, coughing and comes. So that if he says he's coughing, but he goes for goods from China, and he was there 2 weeks ago, immediately you want to make sure, if you were not in the hospital covered with a face mask, you want to quickly make sure, even before you continue with your consultation, your face mask and your gown and everything. And then you administer what would bring relief immediately. Administer and give 1 or 2 medications. But you must still signal the team so that the team comes to assist you. You shouldn't keep that patient at your unit because you think you have all the knowledge to treat. You must alert the team. That patient might be taken out of your facility to a treatment center. So that...
Well, Chairman, the reason why I keep probing for the interland is that you are having complaints that people come, they suspect the symptoms, they are asked to take the samples, they take. Even the transport to move it to the relevant center for testing becomes a problem. I hope you take note of this. But back to the PPEs. You've spoken about Kolebu and what is being done there. But across the country, it's a major challenge. You keep hearing them say again and again, we do not have PPEs, we do not have PPEs. Having worked with the team, what is your assessment of the level of distribution of the PPEs on the ground?
Yeah, thank you very much, Mr. Chairman. I know that, again, just like you do in all areas, we've been trying to upskill the levels of PPEs that are given to the facilities. I would not say I have knowledge absolutely on everything that is being done, but the fact remains that we have to expedite delivery of PPEs to the centers. And if there are any bureaucratic regimes which are tolerated in normal times, we have to find a way to still obey the laws, but at the same time expedite the steps. Because I remember I went to Lekman to consult 2 weeks ago, and the director told me that they have some PPEs, but they wish they will get more restocking. And when I mentioned to the minister in the conversation, he told me that the regional stores had been given some PPEs. And again, it must go through the processes for disbursement and all that. This takes some time, and we must look, I agree, we have to look at expediting the whole chain so that it will go to the ground. So I would pay attention to that.
Last week I heard the Minister for Information, Honorable Kojo Nkrumah, virtually saying the same thing. Oh, we'll try and expedite action, and the persons that have in a facility and they do not have, they should still call and let us. Don't you think that we need to have a system, just as we are trying now to track every patient or people with symptoms, to be able to track where each PPEs are moving into, so that we can tell where we have and where we do not have, and where maybe we have excess and where we do not have excess, so we can even do the cross transportation to ensure that people are safe. You are aware that in UK, now they've just moved away from just saying that, oh, it is when you suspect. Every health worker is just using the PPEs because you don't know who you are meeting for the first time. You may just assume that this is a normal person, as you yourself rightly said. Some people don't show symptoms. So if you don't fast track the distribution of the PPEs, we may end up having a lot of challenge. Mr. Chairman, let me just ask my colleague, what is the real challenge in trying to do this contact tracing and testing? What is the real challenge that we have?
Mr. Chairman, like I said, I was closely involved with the risk communication team. The team that does the tracing are our heroes. They go out there to fetch the cases. I am not privy to any documented challenges, but a few that I can hazard has to do with once you are going to communities to meet people, take samples, obviously understanding them, cooperation and all that, I suspect might be some of the challenges they have. You can meet someone who, after all the convincing that they've come across a contact and all that, they might resist testing. Logistics also. I know that in one of our meetings with the risk communication team, we were made aware that other agencies have come on board, supported with pickups. I suspect these should be some of the challenges.
Mr. Chairman, I want to find out from whether he's aware of a COVID-19 plan, because you need to be able to have a plan that shows how you are going to scale up testing, and then how you are going to intensify your contact tracing as part of the protocol to enable you ease the lockdown. Is there?
But I don't have locus that made me see a lot of documents. So I've really not cited a plan, or that's not to say it's not in existence, but I don't really, I didn't get to sit in a lot of meetings and all that. We normally get all the statements that have come from the quarters, and then we interpret the results and see how to let it go.
But don't you think if there is a plan, even the whole of the country needs to know? You are looking at what New York is doing. Every morning you have the governor tell, this is our plan, this is where we are, this is where we want to get. Don't you think it is something that all of us even need to know so that we can follow what government is doing?
I mentioned the general overarching strategy, which is the 5-pronged strategy of limiting and stopping the importation of the virus. And for each strategy, I know of steps that have been taken to achieve. So this executive instrument to extend the closure of our borders has to do with the first strategy. The second one is the containing the spread of the virus or limiting its community spread. And that is what has informed this enhanced or aggressive, testing, which is actually making us go ahead of most of our peers in terms of the numbers, although we can still do better. The third one, which is adequate care, is what has led us to dedicate the Ga East Hospital as a treatment facility. It's the same adequate care that has made Fevers unit at my favorite Kolebu see some attention. It's the same adequate care that has made us define treatment regimes or protocols for making sure that we support people not to get into a severe case. The fourth one, which is the social limitation of the social and economic impact, is the one that maybe I'll not say we are doing a lot, but I'll not go there for now because but there's a strategy. And the last one is the building the capacity of our local capacity to produce a lot of these items. That's why we are expecting about 3.6 million face masks from some number of companies which have started producing. So this is the broad strategy, and each one has more or less a team that is looking at interventions to make sure that together we are better prepared to manage the situation.
Unless maybe you are capable of isolating your home.
Yes, you have to be moved out of the community into an isolation center, or if you're setting, based on what you're setting and all that, you'll be under some form of mandatory isolation to be observed and treated. Yes.
Yesterday in my community, Asmaso constituency, precisely Pakuso, a gentleman was tested. His sample was taken, tested positive, but they decided that he should isolate with his mother in a single room. You think that is right? It's in a compound house and in a single room. This came up and we had to lock down Kumasi and its environs, and then Accra and its environs. Do you remember the number of cases in Kumasi?
Mr. Chairman, I don't remember the exact figure.
But do you remember it was less than 30?
I don't remember the exact figure, but
it was 8. But let's say it was less than 30. That you are sure for sure it was not up to 30. And the Kumasi and its environs were locked down. Today, we are reporting of Koforidua over 40. Well, Eastern region, Honorable Obi is correcting me, that is Eastern region, not necessarily Koforidua. Will you advise a lockdown?
Mr. Chairman, I mentioned earlier that it's not the absolute figure that will inform a lockdown, but you have to be interested in where the cases are. If the cases are dispersed in the population, some measure of restricted movement would be beneficial. If the cases happen to be at a particular locality, trying to lock down that locality or restrict their movement can also be beneficial. So maybe when I get close to the surveillance team, I'll be interested in all these details to inform a lockdown.
My colleague is aware of the team, from the Director General of Ghana Health Service, the former Deputy Director, WHO. You admit that these are experts, right?
Yes.
Are you an expert?
I thank you very much. Mr. Chairman.
Are you an expert?
The expertise in what? So be specific. What?
Well, expert in public health.
I'm a public health practitioner with a background in public health at a master's level. I don't know whether it's sufficient to be considered an expert. Yes, sir.
Because I heard you in an answer earlier saying that you were going to be, if we approve you, be a deputy minister who will be looking through the advice that the minister is giving. But you agree that those who will be giving the advice to the minister, these are top experts, worldwide recognized experts. So I just want you to have it at the back of your mind that you are going to assist, but these are people who are experts. Last but not the least, the OPDs of Korle Bu is shut down. Is that right? The OPD, Konfanochi, Korle Bu, a number of them, they've closed down their OPDs, right?
Yeah. Mr. Chairman, as we speak across the country, the general OPD protocols have been revised more or less to let the numbers go down to avoid crowding. So in Lekma, every hospital, cases that are not emergency cases, but maybe coming to do reviews and all that, they are advised to postpone them. Some, we are finding mechanisms for them to get their drugs. So you have some who are just coming for a review their hypertensive drugs are finished. We are finding other means to let them come for their drugs without coming to congregate at the OPD. So there's been a revision of the OPD protocols.
You know that this is a major challenge because people start with a simple malaria, if not treated, can get into a very dangerous level to become an emergency. People start with simple snake bite, others start with some other minor thing. So for us to close down OPDs, don't you think that we are risking the life and of the ordinary citizens instead of finding a way of getting people to visit the hospital with their ailment without necessarily crowding and without also necessarily closing down the OPDs?
Mr. Chairman, I appreciate that statement. I will not argue with you, but the point I want to make is that a very good preparation for COVID, just as in every situation, there are a few sacrifices you have to make. You wish other sectors of your service were not affected, but where, in fact, even most hospitals or non-hospital settings, they've asked their staff, not all of them, they've asked them not to represent in the same numbers to work. So we are not in usual times. I agree. We have to find ways to capture people who might.
Mr. Chairman, I thought the philosophy was to save life, and you now understand why we are having more CSM cases in the Upper West. And very soon, if something is not done, it will go to Upper East and the northern regions. Because every year we know at a certain time of the period, certain measures need to be taken. Now we've taken our eyes off all this and we say we are just considering COVID. COVID is to kill people. Others are also dying through other things. Is it not the plan to save life? Whether it is CSM, whether it is COVID, whether it is malaria, our ultimate objective is to save life, right?
Mr. Chairman, kindly forgive me, but we have not necessarily we've not taken our eye off the ball when it comes to other areas of practice.
And,
we are just trying hard to do social distancing, observe protocols that will help with preventing exponential spread with the facility or structure we have now. And Mr. Speaker, let me say that I had an engagement with the directors at the ministry, and what I got to know was that the vaccination regime has still been on, as in giving people vaccines to reduce the numbers of CSM, or if should you even have CSM, the level of severity. But I am informed that in the past few years, about the last 2-3 years, the strain, the meningococcal strain, the organism that causes the CSM, the strain they are seeing is not behaving like the normal strain they've dealt with their vaccines. And they are finding ways immediately to see how that can be contained. But again, there are things we have to do, I agree, like a high suspicion index for anyone who appears with a fever. These are also being escalated so that doctors should suspect CSM more, just like COVID or even more than COVID. So they've not taken their eye off the ball, but there's an issue of mutation, which I've been told, that the strain is behaving unlike the one we are used to. And that is how most organisms behave. When you start attacking them with drugs, they also find a way to go bypass the drug, and then you have to review the drugs you have in stock.
Thank you, Mr. Chairman. My last question. What informed the designation of 400,000 people to be supported with food packages? What informed that number?
Yeah, Mr. Chairman, I'm not too conversant. I don't know what went into it.
Because you notice that the designation of 400,000 people is partly what is creating the problem. I hope you've seen videos of sharing centers and the commotion. In fact, even why couldn't we have considered cash transfers?
Mr. Chairman, yeah. Mr. Chairman, any suggestion that aims at making sure we observe protocols in a better way should be tolerated and not resisted. So,
Because you see, when you talk about cash transfer, it helps you with easy targeting. Bank of Ghana tells us that over 30 million people are using mobile money, right? And all these data are there, such that.
Honorable Leader, you have the ministers, so kindly send your suggestions to them if you have
No,
more
Mr. Chairman,
questions.
the reason why I'm sending to him, because he said he's been working very closely with the team. He's been working very closely.
The communication part, he explained.
Yeah, but they give them briefing, because you need to appreciate what they are doing before you can communicate. And you can just see that even Nigeria is doing well with that. They've been able to target over 10 million people over 35 states. Ghana, we have a LEAP program that have data that we can use, yet we have chosen to do this one that is so difficult to even account for. Mr. Chairman, I just want to find out, why are we also exempting the private health workers from almost all the benefits that we are giving to the health workers?
I don't really know why.
Well, people are telling you, say you don't know, so I can simply run away from it. I mean, let me say, Chairman, Honorable Okoboy is one of my favorite backbenchers. I wish him well. I pray that the enthusiasm with which he conducts himself in the House, he will use the same enthusiasm as he gets to the ministry. I wish you well.
Honorable Majority Chief Whip, do you want to ask? You don't have any question. Very well. Minority Leader.
Chairman, let me thank you for the opportunity and to join you and our colleagues in congratulating our colleague. What I find instructive, Dr. Okoboy, reading your CV, nowhere do I see you proudly mention or declare that you are a member of Parliament for Lejokuku. Any explanation for that?
Mr. Chairman, I got a date wrong, but I think on the second page, it is there that I'm the MP for Lejokuku.
And Chairman, we are vetting you indeed in extraordinary times, that there is a public health crisis globally, which is almost reaching 2,050,000 cases in Africa. You are expected to support your minister and the president to prevent and contain COVID. As board chairman for Kolebu Teaching Hospital, and just to relate to some of the statistics, is Kolebu producing oxygen on its own?
Yeah. Mr. Chairman, Kolebu had a problem with their plant, but the last few months they've been doing some production. Yes.
Are you aware that it's out of service and needed urgent attention? Why did you as board chairman and management not attend to it?
Yes, Mr. Chairman, I'm happy to announce to this committee that the board treated the oxygen situation seriously at a board meeting. As we speak, had it not been for COVID, myself and the CEO would have been to Germany. There's a company that does production of oxygen. They are the ones producing oxygen for the cardio unit. We had a memorandum of understanding with them to come and build an ultramodern oxygen plant, and then we will only be off-takers. And Kolebu was not going to we're not supposed to find money in the setup. So the timelines were supposed to have traveled some few months before COVID made things, made it inappropriate to travel. So we appreciate that the oxygen situation.
But you are aware as board chairman, together with management, that at the time they were depending on purchases from TEMA to get oxygen to run the hospital.
Yes, sir.
Did you consider that right, that somebody was not profiting from the business of selling oxygen to the hospital?
In fact, it was that practice that motivated me to put it as an agenda at the board meeting, that we must be in the position to produce our own oxygen.
Since you are a health professional and part of the government team dealing with this matter, how many tests are being processed a day by Noguchi and the KCCR? If we have to break it down from the 44,421 tests done so far, both Noguchi and the KCCR indicate to us that their capacity is 1,000 a day. So within 25 days, how did we arrive at our figure as a country?
Mr. Chairman, no, my leader did the calculation before asking me the question. So maybe I'll find out what is happening with the figures. Either
Handlings, do you know the figures officially or not?
I don't know, sir.
At the Kwalibu Teaching Hospital, you are aware that neurosurgical procedures, when done, some of the patients had to wait for months before surgery. Were there any plans in your mind as board chairman to deal with a neurosurgery center that will provide additional ICU services?
Mr. Chairman, yes, I'm aware of discussions between the hospital and the ministry for government to consider investing in those areas. We've had support with a new maternity block, the facility that is supposed to come up. We've also had attention to the urology and nephrology unit. We are hoping that we also get some attention.
But are you aware of a worrying statistics that some of the patients, just whilst waiting for treatment for the procedure, die because of the longevity of time they have to spend?
I'm not aware of that.
You have any understanding why obstetrics patients are nursed at the surgical ICU and they don't have an intensive care unit of their own at Kwalibu?
Mr. Chairman, what I can say is that there are challenges when it comes to infrastructure with the maternity block we have now. It's an old structure. The new one will help us with some of these facilities. I will not doubt what you are saying, but these are the reasons why we are working on a new one.
You are aware that Kwalibu is very critical in terms of the health delivery of our country, and there are patients who are already in critical care even before COVID. And whilst COVID is being managed, what are you doing for that category of patients, those in critical care at Kwalibu? Because it appears that many of your staff have been taken away to tracing and tracking centers across the country. What happens to patients requiring critical care?
Mr. Chairman, it's elective cases. That's cases or surgeries that can wait, that we've put a hold on. But the hospital is actually doing emergencies still. So that surgeries that must be done ASAP to save lives are still done at Kwalibu. So that is what I can say.
You are aware that patients with brain tumors, some with cancer, some have had to lose their sight because of the waiting period. Will you urgently address that as if it was also a COVID emergency?
Yes, I will.
I believe you'll be assisting your minister. I believe you quietly, like me, listened to the president in the comfort of your home when he first addressed the country to his second, when he directed that the Minister for Health shall take proactive measures per the provisions of Act 851. what happened and what would you have done if you were deputy minister at the time that the president was speaking to the nation on Sunday on measures to be taken within the ambit of the Public Health Act of Ghana?
Mr. Chairman, I will support the minister.
Support him to do what? Support the minister to do what?
To take actions.
Were those actions taken? Have they been taken? It took the president to come back with an imposition of restrictions when he could have relied on the Public Health Act, which was to deal with the specific health emergency. Chairman, I see the nominee is reluctant listening to whispers from afar. There is supposed to be a governing regulations to the Public Health Act. Will you assist your minister to get that realized for the good of the Ghanaian people?
Yes, I will.
In your earlier answer to the Honorable Samuel Okujeto Ablakwa, you related to frontline officers, nurses and midwives waiting across the country, whether in Wa, in Bekwai, in Tamale or Swami, are expecting that when patients come, they would naturally become frontline officers. Will you by that consider your definition of frontline officers narrow and not encapsulating enough to capture those other persons who are in position to assist in other parts of the country to deal with this public health emergency?
Mr. Chairman, kindly indulge me, but the front line was used just like you call someone trying to score at the front as a striker, and then the midfielder and then the defender. They are all part of the family and the team. So like I said earlier, all of us health workers are part of the team. But I'm happy to say that the leader of the nurses came to say that they now appreciate the definition and that they have been made to understand that is the staff that are actually working at the treatment centers dealing with positive COVID cases.
A colleague of yours named Soji, I believe I get a name right, wrote an article about you to eulogize you as you were being considered for this position. But in one of the paragraphs, he said, at the wee end of your career, just when you were getting to do medicine at Kwalibu, did you have any problems or troubles with any of your superiors, as he indicated in that publication?
Mr. Chairman, well, it's not really problems, but at one of the places where I worked, it had to do with maybe the approach I had to dealing with problems. I asked a lot of questions and all that. And I think we all appreciate that in our setting. Sometimes being too inquisitorial can mean other things. And so there were some few challenges, but they were not devastating.
I will insist on the nature of the problem as I know it. Will you go to the Ministry of Health with that earlier attitude or a change attitude?
Mr. Chairman, I'm a born again. But
given that you are one of the frontline communicators, and given the progress that Ghana have made, evaluation the Ghana specific case, and without recommending the one-size-fits-all approach to dealing with COVID-19, would you recommend an exit strategy or an escalation for Ghana?
Mr. Chairman, once again, these are decisions that will be taken at the table with a lot of consideration to everything. This week and next week, if our figures all come in, we might have to keep the measures we have, maybe. Escalation must have a foundation. For now, I don't have the basis to ask for an escalation.
The whip just asked you about a question. You are a professional. You are not those who are interested in PR, in managing COVID. You are dealing with a health pandemic. Now, OPDs, by their closure, are likely to contribute to morbidity. Is that the case?
Leader, please forgive me, but really, we've not closed the OPDs like in Lekma like this. But we are doing even pre-triage, meaning things have changed. The normal times when you just walk to the OPD have been cancelled. So at the entrance, you are asked why you are around. And if what you say doesn't warrant coming for the OPD, we are giving...
So to put it in my language, what assurance do you have for the Ghanaian public that you are given extraordinary attention to COVID, to the neglect of other elements that is also likely to contribute to fatality of death?
Mr. Chairman, I would like to assure the Ghanaian public that I will continue to keep a broad look at every medical situation and not overly or not spend all our attention on only COVID. Yes, thank you.
Is the National Health Insurance Trust Fund of Ghana and the National Health Insurance Act in distress of Ghana, the NHI of Ghana, is it in distress?
Mr. Chairman, Mr. Chairman, Mr. Chairman, distress, the definition and all that, but what I'll say is that the National Health Insurance as an agency has some challenges, but...
Is it in distress?
No, sir.
Thank you. As a practitioner, what's your thought on the future of specialized training for medical doctors? You want to share a thought with us?
Thank you very much. Mr. Chairman, some few years ago, I think most of us, or most doctors had to go to either abroad or enroll on the West African College to be trained in Ghana and Nigeria. But we as a country set up our college, the Ghana College, and that has helped a lot to train quite some substantial numbers of specialists. It's also training or capacity building is one of the incentives for retaining your medical personnel, and that has also reflected in the percentage of people who will succeed to retain in this country. So we, as a country, we have done well in that area.
I have read about testing, tracing, monitoring to contain COVID. Are you personally satisfied with preparations outside Accra and Kumasi to deal with COVID-19 as a preparedness level of our country?
Thank you very much, Mr. Chairman. Mr. Chairman, constant monitoring is important in dealing with every public health emergency. Whatever we are doing, looking at the number of samples that have been dealt with, there's a lot of work that has gone in. But we can always improve efficiency and get to higher standards. So I would just say that for now we are doing well, but we should not be complacent.
The government in 2015, for the first time in many years, signed a codified conditions of services for health sector workers, including medical practitioners. Given your experience in supervising COVID, which of these conditions of service will you want to see action for the benefit of medical doctors and nurses in Ghana? And other frontline staff.
Mr. Chairman, I know of the existence of that, but I'm yet to fully apprise myself with all the details. I don't want to risk anything here. You know, the associations are very particular about their provisions. Thank you, sir.
PPEs, from where you sit, are you satisfied with the adequacy and sufficiency of personal protection equipment in the country?
Mr. Chairman, we can do more. That is what we can do more about that.
What can we do about it? I've been listening to Honorable Sohini and the complaint from his visit to his constituency, I'm sure many others who have gone home have had experiences of acute shortages. What assurance do you have for the Ghanaian people that government is taking good enough steps to ensure its availability for use by medical practitioners?
Thank you very much. Mr. Speaker, I'm happy to mention that a lot of factories that are into sewing of garments have been roped in to build local capacity. So now we are producing them from within our own country and not to import them. There are a few that we don't have the capacity to produce. The procurement processes have been triggered and we'll do well to do a lot of restocking. Thank you.
When the pandemic broke out, I normally will enjoy some statements coming from you on the floor of Parliament because you show depth in terms of your professional background. But on this matter, I saw you equate Ebola to COVID. Do you still stand that they are about the same?
Mr. Chairman, forgive me, I didn't really equate. The point I made was that Ebola...
Can you repeat the point you made?
Yeah, the point I made was that Ebola is a hemorrhagic fever. It's caused by a virus. The same level of preparation and training you need to manage a case is similar to the preparation you need to handle, let's say, a COVID case. That's to reduce the risk of infection. And I made a case that we had a suspected case of hemorrhagic fever at Tama General. Because of the training the staff had at Tama General, they didn't run away from the case. They managed it, albeit we lost the case. But the point is that just as Ghanaian doctors and nurses and staff manage that case, should we have cases of COVID, Ghanaians will manage them. And I'm happy to say that all the cases we've had in this country are being managed by medical personnel. So Ghana is doing well.
Chairman, the nominee holds promise. No doubt about us, waiting to see the senior deputy minister elevate him above a COVID deputy minister, because that's the impression we get reading from the president. You have a minister who has emerged out of a COVID crisis, but you need to be minister responsible for policy at the health ministry, for infrastructure to assist your minister. But you risk the Ghanaian people saying that, oh, Dr. Okoboy, that minister President Akufo-Addo appointed to deal with COVID. I say he risk. But, Chairman, in concluding, even food meant for vulnerable people, we are seeing some worrying trends of discrimination. Reported countrywide. Now, that's not stimulus package yet for private sector businesses or SMEs. You'll be a minister for states. State resources and party resources are not the same. What advice do you have for the Ghanaian people on this matter in upholding the constitutional principle of non-discrimination?
Leader, state resources and party resources are not the same. Thank you very much.
If you were to give us an idea, COVID-19, the president is very optimistic. Many Ghanaians are optimistic. They are talking of 3 months ahead of us. So instead of the disease determining a cutoff date, we are having our own thinking of a cutoff date. What is your cutoff date as a medical professional looking at the trend?
Mr. Chairman, I'm confident that by the time we end this month and enter into May, our graph should be pointing downwards, and not only downwards, but should be going to levels that are very tolerable and encouraging. And life should be back to normal by the time maybe we complete May.
Chairman, having been board chairman for Kolebu, related to Konfuanati Teaching Hospital and to Tamale Teaching Hospital, I have long shared the view that those teaching hospitals should not be grandfathered by the state. They should be made to run autonomous because they generate enough resources to cater for their needs. Do you share that view?
Yeah, Mr. Chairman, they take care of their needs in terms of the consumables and the things they need to run the facility. But more often than not, most, if not all their staff, most of their staff are paid by the state. If you ask them to do that expenditure as well as pay for capital expenditure like buying equipment and all that, they might struggle. But that's not to say they don't have what it takes to be on their own. I think we also should remember that some of the charges you get from Kolebu, you not get the same at other facilities, let's say private facilities. So to maintain that social order of not denying people health care based on cost, it's important that the state gets involved in some of these facilities.
A cultural lesson to learn from COVID and the number of deaths. Will you expand, as part of your handing over notes as board chairman, the status of your mortuary? Dr. Denchi, who is a pathologist that is doing well, there's a lot of space. Instead of others learning the Muslim way, what do you keep a dead body for? They may not because of religious and other cultural belief, but the Muslim way, you have it easy and then you get rid of the body the next day or the next 2 days. Without that, what will you do for the morgue at Kolebu as part of your handing over notes to support Dr. Denchi and his team there?
Mr. Chairman, the hospital is exploring ways to expand the capacity of the mortuary. But I'm happy to say that even in the mortuary, those that cannot do social distancing are doing a lot of isolation.
Is there social distancing at the mortuary too?
For the dead bodies.
Dead bodies, are they also to do social distancing?
No, not really, sir.
Who sees who and who touches who? Chairman, on this note, I can only join you in wishing our colleague well. I admire him on the floor when he speaks with depth on matters relative to health, and I get carried away by his professionalism, except that day I disagree with him and said that don't treat Ebola, it was COVID. Now you are there. COVID and Ebola cannot be the same, even though you are the professional. So I wish you every success. God bless. Thank you. They are not the same. Then tell him.
Very well. That we've had a long day. Practically every question has been asked. I just ask one if you have any information. When people leave the nursing school, they are called nurses. But there are two categories: certificated nurses and diplomats. Or graduates, that's the other level. Does the ministry have a policy of differentiating between which one they employ and which one they don't? And is that often advertised at the time of entry? Do the students know? Do you have any such information?
Mr. Chairman, I think the level of training determines where they put you in terms of the position, the skill. So if, let's say, you start with as a degree nurse, you've done a 4-year program, where they place you is not like our brothers and sisters who, let's say, are in the traditional training centers. So it's about the position on the skill. But
at the recruitment now, they are recruiting the diplomats freely. The certificated one, those who did certificate, are all outstanding. That's why I'm asking whether there's a deliberate policy to leave one group out and employ the other. If you don't know, that's okay. But please, I want information.
Mr. Chairman, we had the diploma nurses, the nurses. They were the normal practice. Some of these degree nurses were introduced. The programs were introduced recently. So what I know the ministry does is they give clearance, special clearance, for those who, after the diploma nurses, they give clearance for the degree nurses, and they are also admitted in batches. In fact, some of them are in private schools. So sometimes their clearance comes differently from the.
My interest is in the certificate nurses. As for the graduate nurses, they don't have much problem. For all those who are outstanding that come to my attention,
all right,
are those who have certificates.
Okay.
Does the ministry have a policy not to recruit them? If so, do they know at the time of entry of the school?
I'm not aware, sir, of a policy not to admit them, but I'll take a look at it.
Very well. Before I let you go, let me acknowledge these people. Your wife, Mrs. Sarah Boy, thank you for attending upon the house. Ni Ejuri Blankson, Honorable Member of the Council of State, thank you. You know, the face mask is making it possible to identify our senior members. Becholo Niashite Akonfra III, Paramount Chief of Teshi, thank you. Alfred Boy, former Acting Chairman of Greater Accra, thank you. Mordecai Akwashi, oh wow, Mordecai, you were here, I couldn't make you out. Yes, and then Clifford Martekole, Second Vice Chair, Lejokuku Constituency. Great, we thank all of you for coming to support the nominee. Honorable Okoboy, we thank you for attending upon the committee to answer questions. You're discharged for now. You hear from us. Thank you very much.
Thank you very much, Mr. Chairman, and I thank all members of the committee for indulging. Thank you so much. And I thank my people also for coming to support me. Becholo, my wife, and our party. My father is here. Near Ejuri Blankson, Mr. Alfred Boy, and Honorable Minister for Education.
You are discharged, Honorable Okoboy.